All right, so we're going to talk about chronic illness and end-of-life care. And this one is going to be a little bit longer because I didn't talk about it in class today. So I'm going to talk about it now, and your job is to listen carefully. And next week, we will do like a little reinforcement activity of what it's about. And then you will have lecture with Ms. Poindexter for Chapter 5 and 7, and I'm sure she will have some fun stuff for you as well. All right, so chronic illness is a cause of 7 of the top 10 causes of death. They cost the healthcare system about 86% of the $2 trillion that we spend on healthcare. And they are on the rise because our gerontological population is on the rise. So it's important to remember that people who develop chronic illnesses can react variably. They can be shocked, there can be disbelief. People walking around with high blood pressure, they don't even like to admit that they have a chronic illness, but it is a chronic illness. The adjustment to chronic illnesses are affected by many factors, suddenness and duration of the illness, the extent of lifestyle changes, the resources that a person has, the type of personality that they have. If somebody is more, I guess, stoic, they might have a better grasp of the chronic illness than somebody who doesn't do well under those kinds of circumstances. I hope that makes sense. And if they had any previous experiences with chronic illness. So some statistics: half of all people in America have at least one chronic illness, and 25% have more than one chronic illness. When you are trying to define chronic illness, it's kind of difficult because there's multiple definitions that are variable. But basically, a chronic illness is anything that causes lifestyle modifications. Lifestyle factors such as smoking or chronic stress. We live in a very high-stress world, so that contributes to chronic illnesses. We have an older population with longer lifespan, and we have prompt and aggressive management of acute episodes such as a heart attack. And if you survive a heart attack, usually you're going to have some kind of heart issue for the rest of your life. When we manage chronic illnesses, we need to manage more than just the medical aspect of it. People with chronic illnesses are more than just the disease. They have psychological issues, social problems. They might have an altered body image. It affects not just the individual, but the entire family. People with chronic illnesses need to have a good support system because they have to rely on individuals to help them, especially once their chronic illness starts to trend downward. There is more to manage than just the medical problem. I talked about that. The different phases of illness, the book has the trajectory model in it, which is page 30, table 3.-2. And there's lots of issues in the trajectory model. But I mainly want to focus on stable and unstable. So somebody is stable, their illness is basically, or their issue is being moderated. They're not having any issues with it. once somebody is unstable, they are unable to keep their symptoms under control. They can't carry out everyday activities. So they may need more diagnostic treatment, but they don't need hospitalization. Then we have like an acute phase, which is kind of like the unstable phase, but it's worse. The symptoms are severe. They're not relieved by anything without medical management. So somebody could have chronic heart failure, but an acute exacerbation of that chronic heart failure, and they need IV Lasix and oxygen therapy that they can't get at home. Then we have our crisis stage, and a crisis stage is where somebody may have a life-threatening event. So you say you have like a congestive heart failure patient whose ejection fraction, which is how well the heart works, is significantly low, and they are unable to pump blood to their vital organs, and it's caused a crisis event. A crisis event can result, like when a person has a crisis event, it can have a couple of outcomes. One of them is the person could come back from it. The crisis event could cause a downward spiral, and you can only imagine what that means. A downward spiral means that they are not coming back. They are heading towards the dying phase of their life. An example of this downward trend and this inability to come back is patient A. Patient A has multiple comorbidities such as advanced dementia, advanced congestive heart failure, end-stage COPD, and they're not having meaningful communication with the staff or family, and they're unable to participate in their care. Family is blinded, really, because their parent, their loved one, has come back in the past. Doctors, healthcare providers had said that this was the end, but they came back. And so they're unable to accept this. And they end up being in the hospital for way too long. They have very diminished quality of life because at this point it's about the tube in their throat or the peg in their belly to give them nutrition, or the bed sore that they're starting to develop, or the contractions that they're starting to develop. And family still doesn't see that the quality of life is not good. So our role in this kind of situation is to ensure that we make sure there's a palliative care consult so that the palliative care team can come discuss end-of-life issues with the family. Our role is to talk about palliative care, hospice care at this point, really. And it's harder for the newer nurse to do those things because they may not feel comfortable with this kind of material. But it is something that gets better the more and more you have these types of conversations. And these types of conversations need to happen to ensure outcomes that are good. Other characteristics of chronic illnesses, you're not able to keep them under control unless you adhere to your regimen. You generally end up getting more than one chronic disease because they lead to another. It tends to be expensive, so the population that has a lot of chronic illnesses, they are also on a fixed income. And it needs to be collaborative to manage, and it's very easy to get lost in the healthcare system with all of this collaboration going on, because if you don't communicate to the patient, if other healthcare providers don't communicate to the patient and the family, you can get lost in it. And you're living with uncertainty. You don't know what's going to happen. And most importantly to us, nurses, is that it raises ethical questions. When you're a newer nurse, you don't really understand how gray of a line we're walking here. And the more and more you deal with it, and the more and more you see it, the more you realize the futility of it all. But it's hard for family to understand. So it raises ethical questions for us. So the nursing care with chronic illnesses, we can either have direct care or supportive care. So direct care is your hands-on care, your skilled nursing care. So basically being in a rehab facility, being in an acute care facility, or being in a nursing home. That's like direct care. And then supportive care, which is just as important as the direct care, is ongoing teaching, monitoring, counseling. You're working with the whole person, like I said earlier. People with chronic illnesses, especially people that have some preventable chronic illnesses, most of them are preventable, but they have a lot of guilt associated with their chronic illness, like they could have done something to help keep this illness from occurring. But they still have the right to receive care regardless of their lifestyle choices. They have the right to get unbiased care. It's not the nurse's place. It's not the doctor's place. It's nobody's place in healthcare to judge these people. It's our place to help them. So, in communicating with people with chronic illnesses, we must repeat the same information multiple times. It's going to be done. Patients do not understand. Family does not understand. I had an issue where I couldn't participate in my care a few years back, and my husband had to deal with the doctors. So he just didn't get it. And I know that they told him over and over, but he did not get it. He was dealing with the fact that his wife wasn't doing so great. So please remember that telling a patient something once is not teaching a patient. You're going to have to repeat this information, and don't get frustrated with the fact that you're going to have to repeat this information. It's just something that has to be done. Hearing the patient is not the same as listening to the patient. We need to be more open in our communication. We need to give eye contact to the patient, sit down. We need to open up our arms. We need to listen to them. When we are talking with patients and family, we're not going to give them news of chronic, like a new diagnosis. Like, that is not what we do. But we do update them. And when we update them, and when we update the family, we need to be comfortable with that. And we need to know our own biases, because our biases play a big part in how well we give care. We need to not hide behind jargon. We need to be able to explain it to them. If a patient with a chronic illness who is at the end of their life wants to talk, you need to understand that their best time to talk is not necessarily your best time, but to be present for them. And you want to allow the patient and the family member to set the agenda, if you will. So, like I said, there is the trajectory model for end-of-life care. And they have changes in their condition, and one day they're just not able to rebound. So an example, like the patient that is patient A from the previous example, palliative care needs to be consulted, and they come and they talk to the patient every single day, or they talk to the patient's family. This patient wasn't able to communicate. The patient's daughter was present, and the patient's sister came. The patient's sister wasn't there all the time, and she got very frustrated at palliative care for having these conversations, doesn't want these conversations. And palliative care has to be calm and explain that these conversations are important and meaningful, because without them, family will not understand. So being on the palliative care team is a very important thing, and they're highly needed for this kind of big difference between palliative and hospice is a form of palliative. It's just a smaller form, I guess. So palliative is you can be a full code and be on palliative care, and you just don't want certain treatments. You can be a do not resuscitate with treat only, and that's palliative care. But once you're on hospice care, you just want comfort care. And I will talk more about palliative and hospice in a little bit. Please remember that clinicians' attitudes towards the terminally ill and the dying are the biggest barrier to improving care at the end of life. Palliative care and hospice care can improve their quality of life so much. If I live long enough, I plan to be on palliative care and hospice care. They are important bridges between the medical bias from cure-orienting treatment to the needs of terminally ill patients and their families for comprehensive care. When a patient starts to get on palliative care, they are starting to realize that there's no cure, and they will slowly withdraw treatment after treatment. Doesn't mean that they want to end all treatment, but they are starting to comprehend things. And that's what palliative care is supposed to do. It's supposed to help them understand what's going on. It needs to precede a time when the provider realizes that hospice is needed. Hospice is end of life. Palliative care is not necessarily end of life. It's close, but it's not the end. When there's a relationship between palliative and disease-oriented treatment, patients and families benefit more from the comprehensive treatment. So, I already talked about palliative and hospice being important bridges. So palliative care encompasses many therapeutic interventions to help relieve or prevent the suffering of the patient. You have a lot of specialists that have palliative care. When the provider in the hospital wants the patient or the patient family to start considering palliative care, they will call in a palliative care team, and that is all they deal with. So they know how to talk to these patients, and they are comfortable with it. And as new nurses, you're not going to be comfortable with this. It is something that takes time. And in hospice, we'll have a hospice visit towards the end of the semester. They talk about the fact that they don't hire new nurses because new nurses just have a really hard time grasping this concept. And when a patient is on palliative care, it actually allows for life-prolonging therapies. So in palliative care, we have some goal setting. The quality of life becomes of greater importance to the patient or the patient's family, not just the quantity of life. And that's a big debate to try to get patients and family members to understand the difference between those two. Quantity of life just is like how old you can get, whereas quality of life is like what you want out of life. Like if you want to go fishing, can you go fishing? If you want to spend time with your family, can you spend time with your family? So while a patient is on palliative care, they slowly decide to withdraw care. And the family doesn't necessarily want to let go of treatment, but eventually, after being on palliative care and having the discussions with the palliative care team, they will see the benefit of it. It just takes time. So on page 36, you guys have a figure, it's figure 3.5, and it's an algorithm for decision making about diagnostic testing at the end of life. And I think it's a great algorithm. It basically talks about, will the plan be changed from their treatment? If it's a yes, then you're going to go down further. But if it's not, why do it? And I think more providers need to understand this. Like, why do the test if it's not going to change anything? Another thing that we as nurses can do is to educate. Always, always educate. Educate the patient and the family member on the importance of these things. When you are at the bedside and you have the same patient and the same family day in and day out, you get to know them. And you're able to have these discussions with them. And I think that's an important thing as well. Now, like I said, hospice care is palliative care, but it's smaller, it's more defined. Hospice is the end of life, and hospice, their focus is increasing the quality of life. Hospice care is very comprehensive. It has realistic, emotional, social, spiritual, and financial help. If somebody is on hospice pays for everything. Hospice houses, there's respite care, so they will take care of the family or take care of the patient so the family can have a little break. They provide all the medicines. Now, once they go to hospice care, they may not necessarily get every single medicine that they are getting. Like, they will whittle down 20 medicines to like 5. These are the 5 medicines that you need to live. But it is wonderful. Studies have shown that patients get unwanted care at the end of life. And clinicians are not aware of this. Their pain is poorly controlled, and there's not good communication between patient, family, and provider. So the eligibility for hospice, you have to have a serious progressive illness with a limited life expectancy, 6 months or less, and you have to have an informed choice of what the palliative care versus a cure-focused care. Like, you need to know what the difference in that is. Hospice care has been around for 40 years, and we are underutilizing it. People hear hospice and they think that we are giving up on them. They hear palliative care and they think we're giving up on them. And we're not giving up on them. We are just providing a different type of care. Provide culturally sensitive care at the end of life. Different cultures have different things that they want. Some cultures want interdependence more than autonomy, and so they will give a family member the authority on this. Some groups do not wish to withhold CPR. They don't wish to withhold hydration and nutrition. Certain groups like Hispanics, Latinos, extended family, they want extended family with the dying, but pregnant women might not be allowed to attend the funeral. Native Americans avoid contact with the dying. The nurse's role is to assess and to help with whatever cultural belief that the patient or the patient's family may have so that it is developed in the care plan. So nursing care of the dying patient. Well, you need to know modifiable versus unalterable factors. So modifiable are, of course, things that can be influenced, whereas unalterable are things that can't, like ethnicity, age. In the pre-death time, there's 3 critical times, which is pre-death, death, and bereavement. Oh, I put death even. That's supposed to be death event. So in the pre-death, the patient and the family needs to know what is occurring and what's going to occur. They need to be encouraged to talk about their feelings. They need to be allowed to experience pain or experience a feeling of bad. And they need to participate in decisions that will affect their final days. Okay. Whenever a patient enters the hospital, we always assess whether or not they have advanced directives and a durable power of attorney of health care. Advanced directives are like a written document that allows the individual that is of sound mind to document preferences regarding end-of-life care that should be followed when they are terminally ill and they can't communicate his or her wishes. So in general, they're completed in advance of serious illness, but can be completed after a diagnosis has been made. A living will is a type of advance directive in which the individual documents treatment preferences. It gives instructions for care in the event that they're terminally ill and not able to communicate their wishes. And then we have the durable power of attorney of health care, which is specific to health care, and it's a legal document where they authorize another person to be their medical person if they can't communicate to the healthcare personnel. Everybody should have these advanced directives, durable power of attorney of health care, and a living will. It is a very important thing to have. So, symptom management. So, when a patient is nearing the end of life, there's things that are going to happen. Certain things like depression, anticipatory grieving, that is expected because they are dealing with symptoms of the fact that they are going to die and not be here anymore. However, what is not expected is clinical depression. If a person has clinical depression, that is not an inevitable outcome. Clinical depression is something that needs to be treated. So, if somebody is refusing to eat, but they're not like imminently going to die, but so they're refusing to eat and they don't want to participate in their care at all, they don't care about the way they look, that's like clinical depression. Now, things like that happen towards the end of life. There's less like wanting to eat. There's less caring about yourself. But that like is like 2 days and you're going to die. This is within a year. That needs to be treated. People with chronic illnesses have a lower pain threshold, and so they need better pain management. We're really bad about not controlling somebody's pain at the end of their life. We need to manage their symptoms. And like I said, pain management is one of those. If they receive regular analgesics, they should still get these analgesics when they're at the end of their life and they are unable to swallow safely. So if they're getting them, then they should get them continuous by rectal or sublingual routes. And you want to teach the family about how to safely administer. Now, towards the very end of life, you will see patients not wanting to eat or drink. But it can be controlled up to a point. So you can give them appetite stimulation medicines. So if the clinician believes that they're not going to make it longer than 4 weeks, there's a medicine called dexamethasone, which is a steroid. And that will help increase their hunger. But it shouldn't be used for longer than 4 weeks. So if they are not going to pass away in 4 weeks and they're going to live longer, then there's another medicine called Magestrol. And Magestrol will help stimulate their appetite as well. But if their life expectancy is less than 30 days, you don't want to give it. And then there's another medicine called dronabinol, which is the marijuana synthetic. So the thought process is it's going to help decrease nausea and vomiting. They use it a lot with cancer patients. Once a patient does near the end of life, and they are refusing to eat or refusing to drink, there's some things that the family can do, but the family needs to be aware of it. So they can offer small portions of their favorite food. The patient may tolerate cool food better than soft food, or cool food better than hot food, and they can tolerate soft food. You might want to offer them protein shakes, or tell the family to. Make sure that their pain is treated. You can give them ice chips, like you can freeze a fruit juice and give them those as ice chips. You want to teach the family not to argue at mealtime and allow the patient to refuse. This is within days. And then you want to teach the family to help maintain oral care. So nutrition and hydration should not be neglected. However, once a patient gets to the point where death is imminent, you do not need to give them artificial hydration. You are, like studies, they've done studies that show that giving them artificial hydration does not improve their outcome. You're not starving them. You're not dehydrating them. It's a normal process in death. But again, it's something that will happen when death is imminent, not something that happens when death is months away. So if it's months away, then definitely they need to have nutrition and hydration. When a patient nears death, they will also have confusion and delirium. With this confusion and delirium, the family needs to be aware that it's going to happen, and they need to, they can just reassure them and stay close. Sometimes patients will want to get up to go do chores because they see their mother and their mother's telling them to go fold laundry. So you need to reassure the patient, tell the family to reassure the patient, and that is a normal process. And then shortness of breath can be very distressing for families. So when a patient is near death, it's called Cheyne-Stokes breathing. It's just a period, like you have a period of apnea followed by tachypnea. And it's just an irregular breathing pattern. But it's very unsettling for family. So one of the things, we want to make sure that there is nothing else going on that needs to be taken care of. And we decrease their anxiety. We can give oxygen to help the patient and the family member feel like that's helping. And after we've made sure that there's nothing else that needs to be addressed, we can give them morphine, palliative sedation that can be used. And palliative sedation is very controversial, but it is not used with the intent to hasten death. That is the difference between palliative sedation and euthanasia. It is used to help relieve symptoms. So when palliative sedation is used, you want to make sure that there's nothing else that needs to be addressed, such as spiritual distress or anxiety. And once you have assessed that situation and it is pain can increase the respiratory rate. And so this palliative sedation will help not only the patient's pain, but it can also help their breathing. Not sure we explain to family if we are in this situation. In box 3.8 on page 48 also talks about it. But there's going to be expected physiological changes, like I said. And one of them is they're not interested in eating anymore. And when this happens, you just offer. You don't want to force them to eat. And you want to teach the family that. The patient is going to have decreased urine output, and there's really nothing that can be done for this. So you need to let the family know that there's really nothing to be done with this. The only time that it should be concerning is if the patient needs to void and is unable to. They may sleep more, and that is perfectly okay. You want the loved one that's with them to allow this. And they may want to stay with them, but they still shouldn't try to keep them awake. They are going to have increased confusion. Like I said, they're going to see people. When they do have increased confusion, you're just going to remind them of what's going on and where they are. They could be incontinent, and when they're incontinent, you're just going to change them as needed, and you're going to provide skin care. They're going to have Cheyne-Stokes breathing, irregular apneic breathing. The very first thing that the nurse can do or the family member can do is to raise the head of the bed to help improve their breathing. And if this doesn't help, maybe they have some oxygen that they can put on them. They are going to have moaning in the end stages of life, and the reason that moaning is there is not for pain purposes, but it's because the vocal cords are so relaxed and air is passing over them, and this is causing moaning. And like I said, they can see people from the past. They're going to have increased secretions, So we want to, it's called the death rattle. You can place them on their side. You can teach the family to place them on their side, or they might even have some medicines to help with their secretions, such as like a scopolamine patch. The family could place that on them if they have to, if they have an excessive amount. And you want to make sure that they know to provide oral care and to moisten their mouth with a swab so that it's not dry. But family education in this situation is very important, because when you don't educate the family, when they're not aware of what to expect, they're going to freak out and they're going to want to bring their loved one into the hospital. So if somebody's in hospice, the hospice nurse tries his or her very best to be present at the time of death to help soothe family members. So after your vitals cease, you'll see changes immediately. Your body starts to get dusky bluish, cold to touch, waxen appearing, and urine and stool could have evacuated. So what you need to do for family is to place warm blankets on them, clean a dirty patient, and provide a quiet and dark environment. After family has had the time that they need, you should provide postmortem care. And postmortem care involves making sure that the patient has been pronounced or certified. You want to verify their donor status, and you're going to do this through whatever state organization does this. And in South Carolina, they used to be called LifePoint. I think they're called SCOPA now. Then you're going to remove any medical equipment as long as there is not going to be an autopsy. Clean the body before you put it in the body bag, and then you're going to attach your identification tags. One on the foot, one on the bag, and one for personal belongings. This sounds like a good select all that apply question. Very sad subject, loss, grief, and bereavement. Grief is very personal. It can accompany an actual or anticipated loss. You can have complicated grief, which is when these feelings of sadness interferes with the loved one's ADLs. In hospice, they actually provide grief services to family members for up to a year, I believe. That's a wonderful, wonderful benefit. Mourning refers to how the culture or the family will express their grief. So grief is like internal and mourning is external. And then bereavement is the time when mourning takes place. And then through all of this, we have our stages of grief that Kubler-Ross talked about, which is denial, anger, bargaining, depression, and acceptance. There's multiple good things about hospice, but one of the good things about palliative care and hospice is that a patient and family, they have time to go through this. They may not reach all the stages, but if you don't have hospice care, you don't have palliative care, the family or the patient might never be able to reach all these stages. I had a patient a year or so ago who had liver cancer, and he did not tell anybody that he had liver cancer till a week before he died. Imagine like how hard that would be for the family to comprehend what's going on. The day I had him, he was downward trending all day long. Like, I just knew from my morning assessment, he was alert, he was talking to me, he knew what was going on. To my afternoon assessment, he didn't really respond to me. He was confused. He couldn't use the bathroom anymore. And I knew he was trending down. And I called the doctor, and we tried all sorts of things. And finally, I told the doctor point blank that he needed to come talk to this family because this man was going to die. And so that he came and he talked with the family, and the family changed him to comfort care, and the man passed away that night. And it's just so sad to think that they had a week to try to deal with this. Anyways, this is a very difficult and touchy subject, and I understand that. But please understand that it's a very real subject. And with our population aging like it is, with chronic illness on the rise, it's something that we're going to see more and more. And we need to be proactive about it and help our patients and their family understand the importance of hospice and palliative care.